Dr. Williams received her medical degree in internal medicine training at Thomas Jefferson in Philadelphia. Since training, she's had a prolific career in graduate medical education leadership in various institutions across the country, serving as the Associate Program Director of the Internal Medicine Residency Programs at Jefferson, St. Agnes Hospital in Baltimore, UC Davis, and at Wake Forest. And this summer, she'll be taking over as the first female program director in the Wake Forest Internal Medicine Residency Program. She has won numerous teaching and mentorship awards at each of these institutions as an AOA member, Gold Humanism Scholar, and has completed the Harvey Macy Program for educators in healthcare professions. She has published extensively in medical education, learning healthcare systems, and high-value care. She also helped to create the high-value care curriculum for the ACP to help incorporate high-value care residency education in residency and medical education, for which she is here to talk about with us today. I am proud to introduce my mentor and friend, Dr. Donna Williams, to speak about high-value care in hospital medicine.
Well, thank you so much for that, that really generous introduction. That doesn't sound like me, but thank you. Thank you so much, Dr. Poon. Thank you so much for inviting me to talk today about high value care, which is a topic that's near and dear to my heart for a lot of reasons, which hopefully you'll understand as we go on. One disclosure, my husband is a co-founder and co-owner of a medical device company called Certus Critical Care. They do not have any products currently on the market, and nothing I'm talking about today is related in any way. So here's a little bit of an outline of what we're going to talk about over the next 50 minutes or so. I'm going to talk to you a little bit about the problem in healthcare spending, kind of why we're talking about this today. Make sure you have an understanding of what value in healthcare really means. Then we're going to kind of go on some high value care rounds and talk about a few patients as a launching pad for opportunities for improvement, and we'll sum that all up in the end. So everybody knows that we spend an awful lot of money on healthcare. We spend more and more each year. So this graph shows the total healthcare costs in the US in billions of dollars from 1980 until 2019. You see that in 2019, as a nation, we spent almost $4 trillion on healthcare, which is hard for me to even wrap my head around how much money that is. That averages out to $11,580 some per person per year. This currently amounts to about 18% of our gross domestic product, which is estimated to continue to grow and reach 20% by 2028. To make matters worse, our healthcare spending has been rising faster than spending in other areas of our lives. So as an example, if you look at the rise in the average salary of a US citizen compared to the rise in healthcare premiums over the last decade, you see salaries rose by about 1/3, but the employee contributions to family insurance plans rose by 71%. The good news is that this rise in premiums is less than the prior decade. The decade before, the rise was 131% for healthcare premiums. But if prices of other items in our everyday lives grew as quickly as healthcare costs rose over the last 60 years, a dozen eggs would now cost us $55. I think we'd probably eat less eggs. A gallon of milk would cost $48. And a dozen oranges would cost $134. And if you think we have a hard time encouraging ourselves and our patients to eat healthy now, this would be an even bigger problem if those costs rose quite as well. So kind of to add insult to injury here, when you look at the amount of spending in the United States, it's been estimated that somewhere between 1/4 and 1/3 of what we spend, it's wasted care. And the Institute of Medicine defines wasted care as care that either does not benefit patients or harms patients. So in 2019, that was somewhere, in the $800 billion range. So a lot of money spent without good results. When this data initially came out by the Institute of Medicine back in 2009, they had, a group of estimated sources of where these costs went to. That was updated recently in 2019. And these are sort of the general buckets where that excess cost is found. So administrative complexity refers to billing and coding waste, including physician time spent reporting on quality measures. Pricing failure is really about the pricing of medications, lab tests, and studies. Failure of care delivery reflects hospital-acquired conditions and adverse events, including lack of preventive care, which I think is really hard to quantify. Overtreatment or low-value care is where we're going to spend more of our time today, and that is things like low-value medication use, overuse of screening, tests and procedures, overuse of end-of-life care. Fraud and abuse is related to Medicare spending, and then failure of care coordination is really referring to unnecessary admissions and avoidable complications and readmissions. So, while on a national level, there are, a few potential solutions that may require large structural changes, that's a little bit above today's talk. But on an individual level, we can cut the waste by avoiding that overtreatment and low value care category. No one wants to cut care that benefits patients or helps improve outcomes. But in order to do that, we really need to remember that the value of a service that we're providing really depends on the clinical indication. Isn't this why we chose internal medicine to begin with? For the diagnostic process, the evidence, solving a puzzle? This is really an opportunity to go back to our roots and practice what we teach. Take a thorough history, perform an evidence-based physical exam, and thoughtfully order tests and studies that will really add value to the care of our patients. So I'm talking about value a lot without yet defining it for you. Value is certainly something that we expect in all aspects of our lives, whether you're buying a new car or whether you're obtaining a service from, maybe an airline, hopefully in 2021, or from healthcare. And value, generally speaking, is defined as quality over cost. And in healthcare, quality has multiple dimensions. We're going to really kind of talk about these three: outcomes, safety, and service. Outcomes includes things you would expect: patient mortality, complications, also includes things like return to work and functional status. There's a lot of stakeholders that are involved in this value equation, and each stakeholder may put a slightly different emphasis on each of these terms. So patients clearly care about all of those outcomes. Health systems might focus more on mortality and complications, and employers, who are often the providers of insurance coverage, are more interested in functional status and getting their employees back to work. Safety is, really one of the most important determinants of high-value care, and one on which patients, providers, and society really focus, and for good reason. Patients want to be sure that their treatment meets the highest standards, that their care doesn't cause any unanticipated harms, and that their providers are really preoccupied with safety. As providers, we focus on safety. Of course, we want to provide the best possible care for our patients, and there's really a high moral burden when unsafe care inadvertently occurs. Service, of course, is a bit more subjective. The patient experience is influenced by many things. A lot of it has to do with communication. What is our communication time with patients, our communication style? Are we providing patient-centered care? And how hard is it for the patient to navigate their care within the system? And then finally, the denominator here, cost. So cost can be defined in many ways: per line item of service, per the visit, the episode of care, the disease that you're treating, or per year. In healthcare, we think about cost really as the total amount spent per patient over the course of the disease. So sometimes the cost in the short term might be higher, but leading to overall lower costs in the long run. Another way to think about value and quality specifically is to refer to the 6 strategic aims that the Institute of Medicine defined actually 20 years ago. They said healthcare should be safe, timely, effective, efficient, equitable, and patient-centered. And if we keep those core tenets in mind, we will be providing quality care. So hopefully at this point you have a little better idea in mind about what we're actually talking about when we're talking about high-value care. But how do we measure this and identify what is the low-value care so we can cut it out? So I really like this study, which was initially performed back in 2014. So Schwartz and colleagues at Harvard published this, which aimed to measure low-value care that was provided to the Medicare population. They looked at claims for 1.3 million Medicare beneficiaries, which represents 5% of the total Medicare population. And they identified services that were characterized as low value from resources like the Choosing Wisely initiative, USPSTF guidelines, and other peer-reviewed literature. The challenge, as I think you could probably understand, is that the value of the service depends on the indication. So it can be really challenging to use administrative or claims data to identify inappropriate from appropriate use. And so with this in mind, they really dove into 26 specific low-value services that they thought could reasonably be distinguished as appropriate or inappropriate based on the claims data. 1.3 million patients is a little too many to do an in-depth chart review. So their hypothesis was that this limited set of measures could be useful for monitoring low-value care over time if it reflects overuse more broadly. So the 26 low-value care services that they identified fell into 6 general categories, and I've included a sample for each category here. So in terms of cancer screening, I think the PSA example is a particularly interesting one. If you think about the PSA test itself, that's not a very expensive test. But if you remember, we're talking about kind of the cost over the disease course. So the PSA test itself accounts for just 2% of the lifetime cost of PSA screening when you add in biopsies that may be unnecessary and so on and so forth. The DEXA scans is another interesting one under our diagnostic and preventive testing category. There were some studies that looked at DEXA scans as a whole and found that almost half of them were performed in patients less than 65 years old. And while certainly some of those are indicated, some are likely not. And that there were many that were repeated within a 2-year period, so too soon to really affect your clinical decision making. And pre-op testing is something we're going to talk a little bit more later on. It's probably no surprise that there's a robust list of imaging services on the low-value list, including head imaging and syncope and headache, screening for carotid disease, and imaging for low back pain. It's also probably not a surprise that some higher dollar items like cardiac testing and PCI for stable coronary disease made the list, as well as some surgical procedures that have less evidence base. So for each of these 26 low-value services, they compared the use and spending detected by versions of these measures with different sensitivity and specificity. You can imagine if you have a more sensitive measure, that leads to greater capture of inappropriate use. You're likely to capture all of those that are truly inappropriate. But you can have a misclassification of some appropriate use as inappropriate. So for example, if you're trying to determine if there's an overuse in colorectal cancer screening, the more sensitive measurement looked at screening in any patient over the age of 75. But when they limited colorectal cancer screening to beneficiaries older than 85 instead of 75, sensitivity decreases as there's fewer low-value services, but the specificity is increased because you're less likely to misclassify appropriate services as inappropriate. The true value most likely lies somewhere in between. So when they did this for these 26 areas of low-value care, they found that low-value services were provided to 42% of Medicare beneficiaries with the more sensitive measure and 25% in the more specific measurement, meaning that low-value services reached somewhere between 30 and 80 out of every 100 Medicare beneficiaries. So either way, this is a high amount of low-value care that has been provided to our Medicare patients. So how does this relate to overall spending? I pulled just a few of the low-value services to give you an idea of the magnitude of waste that the authors found in this study. Certainly, I think it's not a big surprise that imaging for non-specific low back pain was found to be a very highly overused service, reaching between 5 and 12 of every 100 Medicare beneficiaries to the tune of $82 to $226 million per year. And when you put all of these 26 areas together, that resulted in somewhere between about $2 and $8 billion of waste when extrapolated for the entire Medicare population. So lots of waste out there that we can address. CMS did update this. That initial claims data was from 2009, and since they have this data set, they're updating it every few years or so to see how are we doing. And so they just updated these using 2014 claims data. There was a little bit of improvement, but certainly we still have room to go. So with that background, we are going to go on rounds here and talk about 3 specific patients and what the challenges are and provide some ideas as to how we can provide high-value care in these situations. So our first case is a patient presenting with hip pain. This is Mr. Martin. He's 75 years old. He has a known history of osteoarthritis and chronic alcohol use, and he is coming in with acute on chronic right hip pain. He did one of those, like, kind of slipped out of bed, not a real fall, but ended up on the floor, and he was unable to bear weight on his right leg. He called 911 for help. EMS came and brought him to the emergency department. In the ED, his exam was notable for moderate tenderness over the right hip. They ordered hip and pelvis x-rays, which were negative for fracture, but he really couldn't walk and he lives alone, and so they called to admit him for ambulatory dysfunction. I should mention this is a patient that I did take care of on the ward, so this is a real case. So I want to ask you guys to think about this question. You see Mr. Martin, and you help him out of bed to see if he can bear weight, and he really can't. You try to get him up, standing, and it's not working. What should you do next? Do you say, well, he doesn't need any further testing, the x-ray was negative, let's order physical therapy, treat his pain, and see how we can get him well enough to go home? Do you repeat the x-ray? Or do you order a CT of the hip and pelvis or an MRI of the hip and pelvis? So I just want you to think about that one for a moment. All right, hopefully you have an idea in your mind of which one of these you would recommend. So the real question that we're asking with this case in particular is, how good is the x-ray? Certainly, the most appropriate initial imaging study for acute hip pain is the radiograph. But radiographs have been shown to have limited sensitivity. You can obtain both false negative and false positive radiographs, especially in older patients that are presenting with pain or suspected trauma in the proximal femur and pelvis. Ultimately, radiographs alone cannot exclude fracture in older patients, especially when clinical concern persists. So we really need to think about what is this patient's history, physical exam, and risk factors that might raise the alarm to say, maybe I can't trust that negative x-ray result. And so on history and physical, there are some signs that should raise that red flag to you. Does the patient have significant pain on weight bearing? When you perform range of motion of that lower extremity, is there a lot of pain there? And on the straight leg raise. Those are things on history and physical that can help you determine whether you need to go further or not. Also thinking about what are some risk factors for osteoporosis that might increase this patient's risk for fracture and make it somewhat more difficult to be radiographically identified. And those are this list here: patients who are of advanced age, use chronic steroids, use chronic alcohol, are inactive, and have poor calcium intake or endocrine disorders. So I think you can agree with me that our patient, my patient that I presented to you here, he did have some of these. He had pain on weight bearing, We learned that from the little bit I told you about him. He is an older gentleman with a history of alcohol use. So the thing to do in this case is to go look for advice. So one of the take-homes from this session is knowing that about this clinical decision support tool. So the American College of Radiology has this amazing resource called the Appropriateness Criteria, which are really evidence-based guidelines to assist physicians in ordering the right test the first time. And as with most things, there is an app for that, which is pretty easy to use. So if you go to the appropriateness criteria for this particular case, you can search from by system or by disease, and you'll find acute hip pain. Variant 1, fall or minor trauma, you suspect a fracture, initial imaging. And so as you'd expect, the initial image is a radiography, an x-ray, not a big surprise. The way they set up these tables, they list the procedure, the appropriateness, with the most appropriate best study listed at the top, and then going down from the most appropriate to the least appropriate. They also share with you the relative radiation level in case that's something that you're worried about. So our patient already had the radiography and it was negative. So we move on to variant 2, which says acute hip pain, fall or minor trauma with a negative radiograph. Still concerned for fracture. Next imaging study. And you'll see that the best next test, according to the appropriateness criteria, is the MRI of the pelvis and hip without contrast. CT is also on this list as usually appropriate, but the MRI is preferred. If you are so interested, you can read on in the appropriateness criteria here and find out why this is. And you would read in this section that multiple studies have confirmed that MRI sensitivity approaches 100% in occult hip fractures, while CT, the sensitivity is much lower in the 60s to 80% range. Additionally, they share several studies that have examined the cost effectiveness of MRI in occult fracture detection. This is why the MRI gets the top rating from the appropriateness criteria, although again, they do leave CT as a possibility if you need that. So what happened in reality with this patient? So when I saw this patient, the CT was already ordered, performed, was non-diagnostic, said, well, the read was, no obvious fracture seen. The pain persisted and he really could not bear weight. And we said, well, I really think there's something going on here. So we got the MRI and revealed a non-displaced femoral fracture in the setting of severe osteoarthritis that limited the ability of the CT and the X-ray to identify that fracture. He then underwent operative repair. So how do we look at the cost of a situation like this? I'll tell you that these imaging costs, the femur and pelvis X-ray and the CT hip pelvis and the MRI, I got these from your very own website. CMS, in case you're not aware, requires hospitalists to publish pricing information on their website. So I found these from medstargeorgetown.org and included them here for you. It is interesting to note they put the pricing for every different possible insurance company that you see at your hospital. So for these purposes, I chose the minimum negotiated charge. But it's an interesting resource if you ever take a look at that. I could not find the cost for a femur fracture repair, so I used one that I had obtained from healthcarebluebook.com. So just an idea of the estimate of what these costs might be in terms of how much financially it costs. But cost isn't just about money. Cost is also about downstream effects for this patient. So in this particular case, this led to a delay in therapy. This patient's femur fracture repair was delayed by about 2 days in all. And we know that delay in femur fracture repair does lead to increased morbidity and mortality. This patient also had additional radiation that he didn't need. And this was probably associated with, I already mentioned, an additional night in the hospital, probably some additional labs, all of which did not benefit this patient and may have caused harm. So another takeaway from this example is that, high cost does not equal low value. And the converse is true too. If something has a low cost, that doesn't mean it has high value. So high cost interventions like an MRI is relatively high cost, may provide good value because they're highly beneficial and they get the best care for the patient at the right time. But low cost interventions may have little or no value if they provide little benefit or end up increasing downstream costs. Just pulling this back to that value equation, thinking about the quality as a whole over the cost for this patient. So takeaways from our first case: use available clinical decision support tools such as the American College of Radiology Appropriateness Criteria to help you decide which is the right test. You can also call your friendly radiologist. They tend to be quite helpful. And thinking about how ordering the best test the first time is often worth the higher price tag if that's the case. All right, we've got Mr. Martin straightened away, so we're gonna go see Miss Jones next. Miss Jones is a 45-year-old woman who's coming into the ED with chest pain and shortness of breath today. She was just on a trip to Japan. She had delayed that because of COVID, but finally got to go and came back and came into the ED with shortness of breath. So on exam here, you can see she's tachycardic, she's a little bit tachypnic, and her pulse ox is only 90% on room air, which is highly unusual for her. Her EKG shows sinus tachycardia, no evidence of ischemia, and as you've expected, her CT comes back with an acute PE. So you decide to admit this patient to start anticoagulation and assess what her home oxygen needs might be. So you're trying to determine what level of care is appropriate. Should she be admitted to a general medicine bed? Should she be monitored on telemetry? Or should she go to an ICU or CCU service? So I'll ask you to think about that one for just a moment. All right. I'm going to assume you've made your admission decision here. So as you can imagine, this is going to be a jumping off point to talk about, the use of telemetry. I would imagine many of you were deciding between the gen med bed and the telemetry bed. So telemetry was initially introduced back in the 1960s as a way to monitor patients in the ICU. As with many things in medicine, technology sometimes moves faster than evidence. And we think, well, since we can do that, we should. It must be helpful, right? There are a number of studies that have looked at reasons that telemetry is ordered outside of the ICU and have compared what they see with the American Heart Association guidelines for telemetry. Those guidelines have been updated a few times over the years, most recently in 2017. The clinically indicated reasons by the AHA, and there's a extensive guidelines on this, include many of the things that you would expect. Patients presenting with chest pain where you are considering an acute coronary syndrome, patients who actually have acute coronary syndrome, patients with decompensated heart failure or arrhythmias that are uncontrolled, such as AFib with RVR, patients admitted for syncope, patients admitted with an acute stroke, with severe electrolyte derangements, and patients coming in with overdose of psychotropic medications, things like methadone or cocaine, etc. There's also a lot of things on the common diagnoses on telemetry that are not indicated. Things like GI bleed. I have an asterisk here to remind me to say that, I'm talking about the typical GI bleed patient that we see on the wards. Someone who might need a unit of blood or two, maybe needs an endoscopy, who's hemodynamically stable. There are certainly changes to adjustments to this. Somebody who is critically ill, they're probably going to be in the ICU though and not on the floor, or somebody who is on vasopressin or some medication that could put them at risk for torsades. But your general hemodynamically stable GI bleed patient does not benefit, generally speaking, from telemetry. The patient we're talking about here with pulmonary disease / hypoxia, that is not an indication by the AHA for telemetry. And other common causes that common diagnoses seen on telemetry, pneumonia, sepsis, and acute kidney injury, also not indicated. And in looking at a number of studies that evaluate this, there's a wide range of percentage of patients on telemetry that meet criteria. And one of them only 11% of patients that were evaluated met AHA criteria for telemetry use, so pretty low. But I know you're going to want to know, yeah, but sure, maybe we overuse it, but what is the impact on cost and safety? Safety, we are very interested in, ideally, really over all else. So this study by Benjamin et al. Looked at 4 academic medical centers in Massachusetts. They included all patients that were receiving care outside of the ICU who had at least 1 day of cardiac monitoring. The indications were consistent with those that the AHA has published, and they looked at 2 different kinds of overuse. Patients that were admitted to telemetry that never had an indication for telemetry, and patients that were continued on telemetry after a recommended stop time. For example, someone coming in with syncope, it's recommended that they're monitored on telemetry for 24 hours, 24 to 48. So if that patient stayed in the hospital for 3 days or 4 days and kept on telemetry, that would become a not indicated. So they did better than that study I just mentioned, where only 11% were indicated, but still had a good number of days on telemetry that were not indicated. So in terms of safety, the incidence of significant arrhythmias was much higher on patients where telemetry was indicated, and very low on non-indicated telemetry days. They included the definition of significant arrhythmia in this study included things like non-sustained VTAC, 3 or more beats, AV nodal blocks, and bradycardia, heart rate less than 50 for 30 seconds. So some of these might arguably not be clinically significant, although potentially so. It also should be noted that there were no arrhythmias occurred in patients that were that had entirely non-indicated days. So were admitted to telemetry with no indication in that population. So in terms of cost, they looked at, the data for the nursing time and supplies alone. There are other costs as well. And the average excess cost for their 400-bed hospital was about $250,000 wasted for one hospital. And then, as we keep talking about, the cost is not just financial. There's bed backup, diversion. If the ER has no space and they have to go on divert, that's a big problem. Alert fatigue, I think we all fall prey to that, and work interruptions that may or may not benefit your patient. There's a lot of variability in these studies that look at telemetry. Here's another one that's was published in 2018, looking at a 400-plus bed tertiary hospital in New Orleans. And there they found that, again, a higher number, about 75% of patients of telemetry days were inappropriate in their system. And the estimated yearly cost, if it was used appropriately, was about $500,000. Interestingly, they also showed that there were no significant arrhythmias noted on inappropriate telemetry days. And it, only 5% impacted clinical decisions. So I'm not here just to tell you all the doom and gloom, but what are the solutions? Because there are some. Christiana Healthcare System in Delaware, which is a very large 1,100-bed tertiary care center, they harness the EMR to help solve this problem in their system. So they involved an interdisciplinary team that redesigned and standardized all cardiac telemetry orders in the EMR. They worked very closely with the bedside nurses, provided them assessments that would facilitate safe, timely, and automatic discontinuation of telemetry when it wasn't indicated. They also removed telemetry orders from admission order sets for conditions where monitoring was not supported by the AHA guidelines, although there was always a way for the physicians to order that if they needed to. So I really like this picture because I think it just shows the magnitude of this kind of automatic EMR-based intervention. They looked at the number of non-ICU telemetry orders before and after they changed these order sets in their EMR guidelines. So this is showing 11 weeks pre-implantation and 22 weeks of time after they implemented these changes. So pretty significant decrease in the number of telemetry orders per week. There is a graph that looks very similar to this one that looks at the number of hours of telemetry use per patient that ultimately was a 70% decrease in telemetry usage. So definitely need to tell you about safety and how safety was impacted here. And importantly, over this time frame, they saw no change in hospital census, no change in the number of codes in mortality or in rapid response team activation. They estimated that the daily cost financially for a telemetry patient was around $53, and they estimated their annual savings of almost $5 million. So, you know, certainly seems like a worthwhile intervention to, you know, I'd be happy to get less of those alerts and focus more on care that does increase value. There are many studies that look at a variety of interventions aimed at educating teams about indications for telemetry and really harnessing the interdisciplinary team to decrease unnecessary days. And to the residents, you can be an important part of this. There's an interesting study published in 2020 where a chief resident led a quality improvement initiative working with the daily huddles to work with the physician team, actually sometimes saying, did you know your patient's on telemetry? Do they need that? And working with the case managers that showed a decrease in telemetry use by, I think that one was about 65%. So everyone can be part of the solution. So the takeaway for this case is to increase value, we can think about our telemetry orders. Only order it when it's clinically indicated. And then when the initial indication resolves, maybe that potassium of 2.5 that you wanted to monitor, when their potassium normalizes or whatever the indication was, discontinue it. All right, on to our last patient for today. So this case is an outpatient case where we're doing a pre-op physical exam. So this is Mrs. Clark. She's a 75-year-old woman with a history of high blood pressure who's coming in for a pre-op physical exam. She's scheduled for cataract surgery next month. Currently, she feels well, she has no complaints, and her blood pressure is well controlled on her amlodipine. She does not have any chest pain, nor has she ever. She does not have any dyspnea, or she's never had problems with anesthesia in the past. She's active at baseline and independent with her activities of daily living. Her vitals and physical exam are normal. So the question for you to consider is, which of the following preoperative tests should you order? Should you order the ubiquitous CBC and BMP? Does she need an EKG? Does she need an echocardiogram? Does she need all of these, or does she need none of these? So take a moment to think about which of these you would order. All right, so this case is an opportunity to talk about a few important studies and initiatives. So I'm sure most of you are already aware of the Choosing Wisely campaign. This is a collaboration between the American Board of Internal Medicine and Consumer Reports. They have many lists of things that patients and providers should question. The aims of the Choosing Wisely initiative are to promote care that is supported by evidence, not duplicative of other tests, free from harm, and truly necessary. Most recently, there are over 80 societies that have lists on Choosing Wisely, and they've identified over 450 tests and procedures that are often overused. They also have an app that can be helpful, and they have some really well-written patient-facing materials that you can share for residents. There's a few that are my favorites. There's a great one about why patients don't need imaging for acute low back pain, and another great patient handout on why you don't need antibiotics for acute sinusitis. So there's some really great resources there. But specifically, when we look at preoperative testing, there's a few societies that address this issue that I'm going to point out to you. So the Society of General Internal Medicine says, don't perform routine pre-op testing before low-risk surgical procedures. And you may say, well, of course, as general internists, we know this. We know that this patient going for cataract surgery doesn't need testing. But our ophthalmologist colleagues agree. Their list also says, don't perform preoperative medical tests for eye surgery unless there are specific medical indications, which essentially boils down to, if you would need to order these things outside of pre-op testing, you should do so, but don't do it just for the low-risk eye surgery. This is not news. The New England Journal published a study 20 years ago that looked at 20,000 patients scheduled to undergo cataract surgery, and they randomly assigned half of the patients to undergo standard testing, including CBC, CMP, and an EKG, or no testing, and they found that the overall rate of complications and of canceled surgeries was equal in both groups. So certainly not indicated here. And then one more to throw in for you is from the American College of Cardiology, who says don't perform routine EKG screening as part of a pre-op or pre-procedural evaluation for an asymptomatic patient with low perioperative risk of death or MI. They go on to further explain that unnecessary EKGs can lead to unnecessary consults, surgical delays, and changes to the operative plan that don't benefit the patient. Now, I can imagine what many of you might be thinking right now. First, maybe you didn't have enough coffee to have this deep conversation, and then thinking, well, low-cost tests like CBCs, BMPs, EKGs, in the grand scheme of things, those are cheap. That really doesn't contribute significantly to the problem. So to address that, I can't help you with the coffee, but to address the low-cost test issue, I have a really interesting study to share. So this analysis looked at 44 low-value health services in the Virginia all-payer claims database, which included data for 5.5 million patients in the state of Virginia. They identified more than $580 million in unnecessary costs. And they divided these into quartiles for services that were very low cost, that light blue. Those are services that cost less than $100 per item. Low cost, which were less than $500, and then high and very high costs, which were services that cost greater than $500 and greater than $1,300 per service. The overall waste index, which looks at the proportion of services which were unnecessary, was 31%, which is reflective of that Institute of Medicine data that I shared with you earlier, that's somewhere between a quarter and a third of what we order is unnecessary. Overall, they found that 1 out of every 5 patients received at least one unnecessary service. When you look at volume, which is that top horizontal bar, you'll see that 93% of the unnecessary services were low-cost services. Moving to the bottom bar here, which is cost, the low-cost services represented 65% of the unnecessary services. $380 million spent on unnecessary low-cost services. So it's not just those MRIs and other high-dollar items that make a difference. All those CBCs, BMPs, magnesiums that we just kind of order without thinking too much about, when they're unnecessary, they do contribute substantially to healthcare waste. How does this relate to the case we're talking about? Well, this paper specifically identified routine areas of care that are low value. And the most costly one on this list, to the tune of $227 million, was obtaining lab tests for low-risk patients having low-risk surgery. Of the labs ordered for this indication, they found 78% of them were unnecessary. I think we can agree that we could probably do a little bit better here. So our takeaway from this third case, how we can increase value, is to avoid ordering routine pre-op testing in asymptomatic patients going for low-risk surgery. Also recognizing that low-cost tests that are unnecessary do contribute greatly to overall waste in the healthcare system. I'm not focusing today on, the inpatient ordering of daily labs. I understand that you have had some challenges with the daily orders, as we do here at Wake as well. Definitely part of this discussion, and thinking about how we can decrease those little things when they're not benefiting the patient. So in sum, we spend a lot of money on healthcare. healthcare costs continue to rise. We're spending more and more money every year out of our own pockets and out of our tax dollars. We can be part of the solution, and we can drive down unnecessary costs. This is something that's in our purview as physicians and providers, and how we can really help our patients and our system. I'm going to share 3 ideas of how we can do that. One is thoughtful practice. Trying to be thoughtful about our ordering practices rather than reactive. Focusing on tests and studies that we know increase quality of patient care and drive up the value of care that we provide, increasing that quality in the value equation. The second is to think about practicing evidence-based medicine, incorporating clinical expertise, the best available evidence, and our patients' values. There are some great tools out there to help us, such as the American College of Radiology Appropriateness Criteria and the Choosing Wisely list that we discussed. Some of these can be built into your EMR that can be really helpful to be an on-the-go resource to help you at the point of care. And finally, we can educate our future generations of physicians to make good choices and leave the healthcare environment better than we found it. I've been fortunate to participate in this mission through my work on the ACP High Value Care Curriculum, which is a free resource currently in use at many internal medicine residency programs around the country. It teaches high value care from multiple vantage points. There's cases there that you can go through, and it's really sort of built to inspire trainees to get involved, look for areas at your own institution to improve quality and cost of care. I think that together, with these principles in mind, we really can make a difference for our institutions, for our patients, and for our profession. Thank you for your attention.